Hello, my name is Tyler Watkins, and today I will be performing all of the delivery assistance maneuvers in the pre-hospital setting of shoulder dystocia. Shoulder dystocia's prevalence was recently analysed in a comparative report of 132,000, revealing the prevalence of 1.5% of these pregnancies involve shoulder dystocia, which is indicative of previous studies. In the pre-hospital setting, this makes up very few cases, with many paramedics never encountering this case. Due to the complexity and rarity, significant training and refresher courses should be implemented to be adequately prepared for this scenario. Shoulder dystocia is diagnosed once the head is delivered and a normal cephalic birth does not progress. The clearest sign of this is a retraction of the baby's head against the peritoneum, which makes the baby's head appear to return into the vagina. The baby's chin will appear to burrow back into the vagina. This is known as the turtle sign, and is caused by reverse traction from the anterior shoulder. The baby is caught or pinned under the symphysis pubis, which does not allow normal delivery. Shoulder dystocia is confirmed when the anterior shoulder cannot be delivered whilst applying traction to the baby's head. Safety glasses, gloves, and a gown, if available, need to be utilised. After diagnosis of shoulder dystocia is decided, measures outside the birth itself should be addressed, such as calling for backup, pre-notifying hospital, outlining treatment plan for other caregivers and the patient, and beginning transport if necessary. Look at the individual situation and make preparations for all possible outcomes by identifying all relative aspects. A sequence of manoeuvres will be utilised to safely deliver the child. Each attempt should only last for 30 seconds before moving on to the next option with clear instructions and care. All manoeuvres are designed to change and maximise the vaginal outlet, allowing easier delivery. The first position that will be utilised is the McRoberts manoeuvre. Have the patient position herself in a recumbent position with her buttocks on the edge of the bed or stretcher to best allow access. Request the patient raise her knees high to her chest with a slight rotation of the knees outwards. Whilst the patient is in this position, apply continuous traction in an axial plane direction on the head to continue the cephalic birth. Be careful not to apply too much pressure, which can cause brachial injury to the infant. 60 to 70% of shoulder dystocias are resolved with this mechanism alone. The next manoeuvre is the Rubin 1, which utilises the previous McRoberts position with the application of suprapubic pressure to rotate the anterior shoulder. Additional assistance is required for this manoeuvre. The additional assistance is to locate the anterior shoulder, positioned above the symphysis pubis, and apply continuous pressure on the shoulder in the direction of the baby's face. At this time, traction to the infant head is also applied to assist with the delivery. Hand position should be the same as the resuscitation compression grouping. This is to be attempted for 30 seconds. The next manoeuvre to be attempted is the rocking Rubin or Rubin 2, which is the same manoeuvre as previously attempted with an additional slow rocking motion. This is done by slowly moving the suprapubic pressure in a rocking motion, which assists the rotation of the infant's shoulder. Keep the patient on her back in the Rubin 1 position and apply the suprapubic pressure. Explain and ask the permission to perform the next internal manoeuvre known as the Rubin 2. The fingers of one hand are to be placed into the vagina and are used to locate and rotate the anterior shoulder towards the chest of the infant. This movement will hopefully unimpact the anterior shoulder, allowing enough room to deliver the rest of the child. The next manoeuvre to attempt, if the infant is still not progressing, is known as the wood screw manoeuvre. Leave the initial fingers inside the patient that have located the anterior shoulder. Insert the other hand under the infant's head and locate the posterior shoulder and apply pressure on the chest side of the shoulder. With both hands, simultaneously rotate the shoulders in the direction of the child's face in an attempt to dislodge the posterior shoulder from the suprapubic bone. This attempt should only last for 30 seconds. The second hand is to gain more traction and to further control the rotation. In all of these maneuvers, attempt to keep the head in alignment with the shoulders. This manoeuvre is known as the reverse wood screw and should be explained to the patient. The manoeuvre is the same as the wood screw but with a reverse in direction. Locate the other sides of each shoulder and slowly apply pressure to rotate the infant's shoulder 180 degrees under the bone to dislodge it. The next maneuver is known as the delivery of the posterior arm. The elbow of the posterior arm is located, swept across the face of the infant to allow anatomical ability of the shoulder. The arm is then manipulated out of the vaginal opening and delivered. The difference in width with the posterior arm delivered should allow for the rest of the infant to be delivered. This is the last internal maneuver based on the potential risk of injury to the child and the mother. Monitoring of both patients should be prioritised due to potential hemorrhage for the mother and trauma or neurological related injury to the child. The next position is the reverse Mick-Roberts and involves manipulating the patient's position. Instruct and advise the patient to position herself on all fours. Once the patient is in this position, ask her to elevate her buttocks, flex her hips, and ask her to place her head as low to the bed as possible. Apply the same traction as the original Mick-Roberts position for 30 seconds. This position uses gravity to manipulate the opening and the impact of the baby's shoulder against the bony structure of the pelvis. Following cephalic birth, dry the child and assess the muscle tone, breaths per minute, and pulse by monitoring the pulse through the umbilical cord. If normal, place the child onto the mother's chest, utilizing skin-to-skin contact. If the child does not meet these markers, begin resuscitation. Perform an APGAR score at 1 minute and 5 minutes to monitor child effectively. Clamping of the umbilical cord should be delayed until 3 to 5 minutes, with the cord being clamped 10, 15 and 20 centimeters. The cord is to be cut at 15 and 20 centimeters. Continue supportive cares for the mother and child. Administer 10 units of oxytocin IM to the mother to promote placental separation and uterine contraction. Training for this scenario should be done semi-frequently for paramedics due to the potential deterioration of these patients. Individual cases and surrounding implications such as location of patient, condition of patient, distance to appropriate hospital, size of pre-hospital team and their training should be reviewed to provide best care for the patients. This technique is based on the help of mnemonic. Thank you, and I'm Tyler Watkins.